I'm Gigi Godwin, President and CEO of the Montgomery County Chamber of Commerce. It is my pleasure to welcome all of you, our Board of Directors, members, and invited guests. Thank you for joining us today for the Chamber's first ever virtual Health Systems CEO panel on a topic of great importance to us all: how the COVID-19 global pandemic has shaped our region's healthcare systems and what that means not only for the future of healthcare, but also what it means for each of you as our region's business leaders, as you plan for the next phase of not only re-entry to the workplace, but your overall business recovery processes for your companies, your customers, and especially for your employees. As a reminder, we are recording today's presentation, but the presentation and the slides will be made available to you all. And please send us your questions today by using the chat box feature. I want to introduce our VP of Government Relations, Trisha Swanson, who will be a co-moderator, and our wonderful admin assistant, Juliette Chukwu, who is managing the technical support that is so important to the success of an event like today. And now, before we introduce our esteemed panel, it is my pleasure to introduce our Chamber's Board Chair and Group Vice President for M&T Bank, Lowell Yoder.
Thank you, Gigi. And I want to thank our health system CEOs for their participation here today and for their exceptional leadership through this global pandemic health crisis. Our goal today is to provide this valuable and unique opportunity for our business leaders to hear from our healthcare thought leaders, and for each of you to benefit from their CEOs' lessons learned. Going a little off script here and asking forgiveness from my fellow bankers, but usually the financial system is the reason for economic turmoil, but not this time. This time it's a health crisis. And it'll be very difficult to find a solution to the economic problem without first finding a solution to the healthcare issue. And my sense is there is no better healthcare system and no better healthcare leaders in this country to help tackle this issue than the folks we have on the call today. The institutions these folks represent have not only jumped in to cover the crisis at hand, but they've maintained their day job of providing ongoing health care to the community. And we hope that you will come away from today's discussion feeling confident that our families and our employees can resume all the necessary hospital procedures and care to ensure health and wellness. Please join me in thanking our fellow Chamber board members for building this experience for us today. Thank you, Bridget Plummer of Adventist Healthcare, for moderating today's panel and for coordinating this event with your fellow healthcare systems Chamber board members. Anise Cody of Holy Cross, Leslie Forde Weber of John Hopkins, and TJ Senker of MedStar Health, who had the original idea for this panel. Thank you all for your thought leadership and commitment. And now it's my pleasure to introduce Bridget Plummer, Montgomery County Chamber board member and Director of Operations for Urgent Care Services for Adventist Healthcare, who will introduce each of our esteemed panelists and share a brief overview of current COVID-19 data on the state of the nation and our region. Bridget?
Thank you, Lowell. Thank you for joining. It's an honor to be able to facilitate this panel discussion as a united front with our Montgomery County hospital leaders. They are truly at the helm of what we are doing, and they can discuss with us what it means to the community as business leaders and as employers. As you know, COVID statistics are ever changing. Nationally, we are seeing our numbers hit close to 6 million. And the COVID cases, because of, sadly, we've also had 170,000 deaths reported. And Trisha, if you could put that up, I would appreciate that. We can look at our national, there we go. And it's stifling. And being a registered nurse myself, it really puts us on the forefront where we've never wanted to be so forefront, but we are right now. So you can see them nationally and where we are with Maryland, into the orange, and we have a high statistics. And I specifically, if you look at the next slide, we can look at Maryland. And our report for this is we have over 105,000 cases. We have 3,500 deaths. The highest numbers that reside in our community, again, is in our backyard. We have crested over 19,000. This is a 3.25% positivity rate for the state of Maryland. I would like to see it go to 0, but that was wishing with high hopes. These are stifling. So go to the next slide. And what I would like to also look at, when you look at our statistics, you can see I've actually put up the statistics on the testing. And you can see we have done over 216,000 testing on individual people in our community. And that's kudos to the people that are on this panel today. So we want to be able to give them an opportunity to speak about this, to acknowledge it, and talk about the great work that they are doing. So when the Montgomery County Chamber of Commerce approached me about this, we definitely wanted to provide you with an opportunity to see our healthcare leaders and to allow them to address these high-level questions. But I want to do first a little housekeeping and to ensure that we have a cadence around our panel discussions and to understand the formatting of the meeting. First, I will pose a question to each healthcare leader that has been vetted through the chamber. And then second, all of those questions have been addressed that I have been able to pose. I will then move the discussion to talk to Dr. Andy Catenzero. He is our epidemiologist in infectious disease. And then towards the time does allow, we will open up a Q&A session. With doing that, we would ask for you to pose the question through the Teams. If you raise your hand and type your question into the Teams program, we will then ask our leaders to answer those questions. So in respect of your time, let's begin. I would like to do some introductions. First, I would like to introduce Jackie Schultz. She is a registered nurse, has her master's, and she works at and is the president of Suburban Hospital and Johns Hopkins Medicine affiliate. We also have Dr. Van Coots. He is a physician as well as the president and CEO of Holy Cross Hospital and Trinity Health. We have Terry Forde, who is president and CEO of Adventist Healthcare System. And then we have TJ Senker, who is also the president and senior vice president of MedStar Montgomery Medical Center. So thank you for joining our panel. And then again, we have Dr. Andy Catenzero, who is our infectious disease and epidemiologist. So with that being said, let's start with our first question that we have. So let's start with our first question, and this will be for Jackie Schultz. When COVID-19 became a reality for Montgomery County, how did your hospital handle preparation for safety concerns? And why is it important for the community to be aware of what you're doing?
Well, thank you, Bridget, and thank you to the Chamber for inviting us to let you know a little bit about what our worlds have been like over the past couple of months. So what I'm about to tell you will probably be applicable to the rest of the Montgomery hospitals too. But let me emphasize initially that really everything was about safety when it comes to COVID. We had to be thinking about keeping patients safe, the patients that were here, both the COVID patients and the non-COVID patients, and keeping our staff safe. So those were both major concerns. And in that way, quite frankly, our community was the recipient of all of those concerns, and that kept them safe. We needed to make sure that we always had adequate caregivers for the community members who needed hospitalization. It was a primary concern. And then by assuring that we didn't transmit COVID to non-COVID patients within our facility. Now, one of the major challenges with COVID, and I know my colleagues are going to agree on this one, was that our information really was evolving. The disease was only known through maybe December and January in the world, a little later in our country. So we were learning together and fine-tuning all of our directions to staff and patients and families about safety and about care in real time. Now that meant that we were revising care over the months that we were experiencing it. And in every case, we were incorporating the very latest information we could get from the experts. But it did mean that there were changes. Communication has really been the key through this entire episode. That meant we used every means. We communicated verbally on units and by memo and by Zoom meetings and telephone calls, and frankly, just by rounding. Rounding is when leaders go out right to the bedsides and make sure that they're connecting with staff. And all of our leadership stepped up rounding. We amplified it beyond our usual practice so that we were there on all shifts and on weekends. And that was really necessary because our staff, too, were intimidated by what was unfolding before us. Now, what we all really used as a paradigm to help ourselves get this crisis was a model that exists out in the military and the community, and that was the Disaster Preparedness Command Center model. So we used that, and we opened up our incident command. So we considered COVID an emergency, a disaster, and this allowed us, through the entire surge, to organize ourselves on our efforts. Now, we're very lucky at Suburban because we have had a decades-long partnership with Walter Reed for emergency preparedness. So this was very easy for us to incorporate, but we incorporated it across the Johns Hopkins healthcare system too. So we all had command centers open, and I know my colleagues across the county did too. The advantage of using a model like this is because it really is inclusive of not only organizational impact, but community impact too. Now, when I start talking about safety, I'm going to divide it into three categories. First of all, the physical environment and where we would put patients. And I mean patients with COVID and patients without COVID. And then all of what you have heard about extensively in the news, which is the personal protective equipment. What would we use and when would we use it? And third, all our protocols and practices around testing for COVID and the actual care of COVID patients. So the physical environment for all of us was a challenge. We chose right from the beginning to leave the COVID and the non-COVID patients separate on separate units. So we would never have a space with both COVID and COVID patients, non-COVID patients in the same place. All of our patients were in private rooms, but the units themselves were designated. Now, this allowed us then to make sure we were fine-tuning whatever personal protective equipment was being worn, and it also helped us control airflow. And now I'm gonna try to make this straightforward because I think we all learned about this, but as there is a suspicion that COVID may be airborne, it may be transmitted in the air, we had to ensure that we had negative airflow that would optimally protect staff and patients. And essentially that would mean that the air from a patient room with COVID would exit the facility. It wouldn't be recirculated back into the rest of the hospital. This is what we do for patients with tuberculosis, for example. And most of us have some rooms that can accommodate this, but not the number of rooms we would need for COVID. And so what we did at Suburban was that we used portable HEPA filters, air scrubbing filters, and those were put up in rooms, and then those were exhausted through an exit vent out of the hospital. And in addition, we had to construct, we call them Auntie Rooms or doffing and donning. It's the place where you put on the equipment or take it off, but what it really is a sort of an airlock, so that again, you don't mix the air between COVID and non-COVID. And then staff would wear the appropriate personal protective equipment in these spaces. Now, I want to stop and just mention now that you've probably heard in the news that many community members delayed care, important care, because they feared of getting COVID in the hospital. And I want you to know that all of this was the critical work we did and we continue to do to make sure that this kind of transmission doesn't happen. I want you to know that our hospitals are safe, and that I mean all the hospitals in Montgomery County. We've had very little transmission. And so we don't want the community to continue to have chest pain and not come to the hospital because they're worried about COVID, for example. Now, PPE was the next category, and I'm sure that we've all heard about the shortage across the country. This had significant impact. And we went into conservation mode, which meant that we were following guidelines for the use of equipment that you would do when you were in emergency preparedness circumstance. And the CDC has very carefully outlined what that is. Now, cohorting helped because we wouldn't use those special masks, the N95 masks, in any location that didn't have COVID patients, so that saved those masks for those units. But you know that eventually we all moved to what we call universal masking, just like we do now in the community, where everyone was wearing a mask to cut down on any possible transmission. And then we moved as well to face shields. Think of it, it looks like a welder's mask actually, but it's worn in front of the face and it's plastic. And it too, it serves a double purpose. It protects the eyes, but it also preserves the mask. So since we're conserving, it kept our mask cleaner. Now we knew that this was keeping staff safe, and this also ensured little transmission. I want you to know that we're still in PPE, that personal protective equipment conservation mask, and not all in mode, and not only for masks, but isolation gowns as well. So our staff were wearing isolation gowns. We've had to move from disposable to reusable. And I think that's going to continue way into the foreseeable future. So these things worked. The PPE worked. We saw little transmission. And we also, of course, were doing social distancing as much as possible. And you can't really social distance to give direct patient care. Thus, PPE was very important. And of course, hand washing. So you should note this as a community because this is going to work in the community as well. And this is incredibly important. A couple of words about testing, because it is a prep and safety issue. Test kits and test reagents were in short supply, and we are finding that they remain in slightly short supply. The information about who to test and when to test evolved, and I think you know, because there just came out something from the CDC today that it continues to evolve. And the different information we're getting really is all about ensuring that we always have adequate tests to test a patient for COVID when they come in here with potential symptoms. Now, remember, in the hospital, we really do need to know if you have COVID or you don't have COVID in order to put you in the appropriate unit to ensure your safety and the safety of other patients. That means if you've read the list of COVID symptoms, they are definitely broad. And some people present asymptomatically. So gradually over time, we moved to testing all inpatients, whether they had COVID symptoms or not. This allowed us to keep beds available, and this allowed us to put patients in the right setting as close to the beginning as possible. We were fortunate that we had the ability to do stat tests, rapid tests, with a quick turnaround time. What really helped us was using our Johns Hopkins Medicine supply chain. They were great stewards of supply. So we conserved. So I don't want to think we had as much as we needed, but we were never worried that we would have to face a staff member or a patient and have nothing to wear. And finally, of course, there are some safety concerns about the care itself, but I know that our physician member of the panel is going to speak a little bit about this, but I know you've heard across the country about ventilator shortage or hospital bed shortage, medication concerns. Now, in this case, I think two things helped us. First, being part of a system, because we were able to look at aggregated resources and we would put the resources where the patients were, which, by the way, in the Johns Hopkins Medicine System was down here in Montgomery County. But you should know that our colleague county hospitals also kept in close contact. Their CMOs, their chief medical officers, were communicating so that if there were questions about resources and about care, we were sharing information. You know, I believe this is also a huge contribution to community safety because we're all getting the best information that we all have at any one time. Now, I want to mention visitor restrictions because from a hospital perspective and a community perspective, this is a painful topic. You know, this was a difficult decision for all of us to decide that we would limit or restrict visitors. And it remains a difficult decision to decide when we will relax those restrictions. but it was necessary. Again, what we were thinking about was staff safety. And so when we think about keeping our staff safe, that is a direct connection to how we're going to serve the community and keep them safe. So we moved to restrictions that helped us conserve PPE because we would have to provide that to visitors. We did, of course, have times in which we made exceptions, as we always do. But we will now start to re-examine these policies to determine what's the right thing to do moving forward, and how do we move forward now, keeping in mind that we're still vulnerable to what was our prior practices. So I think in these ways, we really did have safety in mind for everything. And in this case, we were in lockstep with the community. I want to mention too, just a community response for a second. And it's not part of this presentation, really. It's not relevant, but it is so relevant. Everything that our community members did to lift the spirits and acknowledge the staff's crisis with COVID had an incredible impact. I cannot tell you what an impact that had to staff that were facing this every single day. Even when we saw people marching outside with the banners outside of Suburban a little later into the surge, it is totally spirit lifting. So the surge may come in the fall. I sincerely am hoping that we avoid any kind of a big surge, and I am happy to be in Montgomery County, where our county leadership has been very focused on this, and as a result of that, we have had a lot of compliance and we've seen our numbers drop. But I do think that as a community members, you should know that we've learned so much through this first surge that we will be better prepared no matter what. So I thank you for listening.
Oh, thank you so much, and to giving such detail and comfort and knowing that you've gone to great lengths to ensure that not only the safety of people utilizing your hospital, but also to your staff members. And I commend you on that. So thank you, and I appreciate your input and your communication about this.
Thank you so much, Bridget.
Sure. Question number 2. Dr. Coots, I'm going to push you up to bat. I hope you don't mind. During the first months of COVID-19, many elective surgeries were postponed. Where are we now with the elective surgeries and procedures, and why is this important for the community to move forward?
Well, thanks, Bridget. And I'd like to thank Jacky, too. Jacky gave a really great review of how all of us prepared and moved into crisis operations when the pandemic hit us, and then moved through pretty much stabilization operations, too. When the emergency order was put in effect, one of the requirements of that emergency order was the cessation of elective surgeries. And I'll say that, emergent and urgent surgeries did continue throughout the crisis, but those elective surgeries, those that were felt that could wait, were put on hold. I think, honestly, there were a few negative ramifications of that, because some of those elective surgeries over time actually wound up becoming a little bit more urgent by the time that portion of the emergency order was lifted. And that was lifted around sometime in mid-May. And so elective surgeries have come back. They were slow to come back originally because there was still a lot of fear in the community. People were unsure that we could guarantee that there were COVID safe zones or COVID free zones. And everyone was afraid that if they came to the hospital, they didn't have COVID, they would sure have it when they left. And so we had yeoman's work to kind of develop and reinstill a level of confidence and trust in our patients. And I think all of us did some variation of creating COVID-free or COVID-safe zones. Now, why is this important? Well, obviously, reestablishing the trust is very important. I mean, trust is a big part of our business. You are trusting us with your health, your well-being, often your very lives. And so that's very important to us to maintain that level of trust. It's important for the health and well-being of the community, and it maintains the workforce. So getting people in, getting them the care that they need, whether it's an elective surgery or an elective special procedure or something like that, was very important. So convincing the doctors to convince the patients that it was safe to come back was job number one. The importance of developing that community member faith and confidence in the health systems across our county cannot be underscored. I mean, I think that was very important. And so really what we're in is a para-COVID environment, as we like to call it. So we will be in this para-COVID environment for some time. COVID is going to be with us. And even after we get a vaccine, COVID-19 will still be with us. And so those things that we put in place today, in the world, in the new normal, will continue to be in place over time. And so we all did certain things to ensure the safety and well-being of our patients, of the surgeons and the specialists who are doing the procedures, and our staff as well. So in creating those COVID-free zones, we cohorted COVID versus non-COVID patients. We already had increased the cleaning of high-touch areas. We redoubled our efforts to ensure that was clean. And for anyone in the hospital, you could see the cleaning actually happening with a much higher frequency than would be under normal operating procedures. We had separate entrances and exits for COVID, non-COVID patients versus COVID. And we originally had that no visitor policy. We continued to maintain that no visitor policy for a while because having no visitors also helped to ensure the safety of the patients and our staff members as well. And of course, over time, we have tailored that to allow someone to accompany the patients now when they come for surgery, and certain categories of patients that can be visited. And that is modified over time. And of course, if we have a surge, a phase 2 surge this fall, that also collides with the flu season, we may well ramp those back up and tighten those visitor restrictions back down. Testing every patient that comes in for surgery or special procedures was another thing that was implemented to ensure that it was a safe environment. And if this patient was, needed the surgery and was COVID positive, you had to take special extra precautions. Now, we were already treating every patient as if they were potentially COVID positive, but having the confidence of knowing that they were versus not, I think was very important for the morale of the staff as well. And then it's certainly aspirational that if we have enough reagent for the analyzers and have that capability, we all really do want to test every patient that comes into the hospital. We want to get to that point to truly ensure that we've got well-known patient population. And if they are COVID positive, if they're COVID positive mothers that are coming in to deliver, et cetera, they can receive the appropriate care, and the staff knows and is aware and can take those extra precautions in caring for those patients. So I'll leave that answer as sort of being answered now. I do want to echo what Jackie said also, though, in thanking the community for all of the support that they had from the businesses that provided us with PPE. There were construction companies and other companies that gave us their respirators, gave us gloves, dentist offices and physicians' offices and veterinarians that were closing down temporarily gave us a lot of PPE. Businesses and community members brought meals for the organization. I think we had about $500,000 worth of meals that were provided to us during these 28 weeks of crisis operations. And then a special kudos goes to those in the community who are making masks, not just for us, but making masks specifically designated for us to give to every patient who is discharged from the hospital, and not just to every patient, but to every family member in that household as well. Because many of the patients that we would see were essential workers. Many of them are the working poor. Many of them would tell us that they could not afford the masks for all of their family members, and they were living in multi-generational homes or multi-family homes. And so, potential for super spread of the virus in the very backbone of the workforce that we needed to maintain our infrastructure. So to be able to have the community donate masks that were specifically targeted for that population was a big boon for us and a big help. And so I can't thank the community here in Montgomery County enough for their support in that. And so, Bridget, I'll turn it back over to you.
So thank you, Dr. Coots, for bringing this information. You were very thorough on providing us information on feeling safe coming back into the hospital. And it is vital that knowing healthcare concerns still happen and we can't be COVID centric. So thank you. I appreciate your input on this. Okay, question number 3. Terry Forde, President and CEO of Adventist. What are the key lessons learned from COVID-19? How has this shaped the model of healthcare, the access and the delivery?
Good afternoon, Bridget, and thank you for the opportunity to be a part of this. I think there's really 3 key learnings I'd like to focus in on that I think are relevant, and they're very important actually. One of them is actually a call to support and a call for help for those of you that have family members that are considering working in the healthcare field. So the first one is an affirmation of our healthcare professionals, our healthcare heroes. You know, you've seen on TV the different signs and the different recognitions that have gone on. And in this community here in Montgomery County, as Jackie and Dr. Coots said, we had an enormous amount of support of people that came out and recognized all of our healthcare professionals in the best possible way that they could. But I want to share with you a little bit of some inside stories of what I saw from healthcare heroes within our organization. First of all, nurses, physicians, dietitians, environmental service team members, team members drawing blood from our patients, whatever job that they were doing before COVID-19, they continued to do in a remarkable way during COVID-19. Yes, they were scared. If you guys go back in time, you remember New York City and Seattle were the 2 major metropolitan areas that got hit pretty early. New York City, much more than the West Coast. And this area of Maryland was about 3 to 5 weeks after that. And we watched what was happening in New York City with some of the hospitals getting overwhelmed. And so there was definitely a fear and a worried outlook within our healthcare professionals. But and I can say this is true for all the hospitals here in Montgomery County, everybody was there during this pandemic in a very real and palpable way. They showed up every shift, they worked nights, they worked extra shifts. As we saw the census increase, in fact, in our hospitals, most of the Montgomery County hospitals saw at least a double increase in our intensive care census levels. In some cases, we tripled the size of our intensive care units. And so that meant quickly hiring additional nurses and physicians and team members that could come support that increase in our census. You know, some of the stories that I think back and draw upon were we had nurses that had brand new babies at home, and not knowing exactly how the spread was happening. I remember talking to several nurses that said, Terry, I don't even go home. I stay in a hotel. I'm not even going to go home to my family so that they can be protected. And so there were literally weeks, in some cases a couple of months, where we had team members not be able to be with their kids, be with their family members, and to miss out on those warm hugs and to be able to be with their family and take care of them was definitely a sacrifice for a lot of our team members. But you know, I think the overwhelming support that was shown from the community through many different ways was that lift that was needed. So we had drive-by parades happening. We had cards. We had food from restaurants that were delivered to the hospitals. I mean, just an amazing outpouring of support. That extra lift made a difference. Now here's my call and ask for you as you're listening to this. We have a great need for healthcare professions. The reason they go into it is to really provide compassion and provide healing to others. So when we look to the future, if you have kids at home, if you have nephews and nieces, if you have family members that are thinking about, well, what profession should I go into? I want to invite you to offer to them, think about healthcare. It is truly meaningful work that makes a difference in people's lives, and we need more healthcare professionals. There's a lot of nurses that will be retiring and have plans to retire, and we'll need to continue to replace them with that same kind of spirit that we saw during this pandemic. So be that encouragement for us. That's one way specifically you can help us, is encourage young people to think about healthcare for their profession. Number two, the second lesson that I think I walk away with is, and Dr. Coots touched on this a little bit, but during the pandemic, we saw upwards of a 40 to 50% drop in ER volumes, the cancellation of elective cases. People that were sick stayed home. I mean, there was truly great compliance with the stay-at-home orders here in Maryland, and specifically in Montgomery County. The challenge that we saw over time as this pandemic grew into multiple weeks was when patients got sick enough that they had to come in, they were really sick. We saw a delay in care from seeing their physicians in their offices. We saw a delay in those annual health physicals. We saw longer recovery times from patients when they did come into the ER when they were really sick, and delayed that care. And that was discouraging to our physicians and to our team members that were taking care of them, knowing that even during the pandemic, we were ready to serve them. We did have capacity to serve them from an emergency standpoint. We were also disappointed to see the increase in areas like addictions, whether that's alcohol or drugs. We saw an increase in sexual abuse in homes in Montgomery County. We saw an increase in mental health visits. And I think the lessons from that are, we've got to absolutely make sure that during a pandemic that there is excellent and great awareness that you can still access your healthcare providers. You can still get the care you need during a time when you need it the most. And unfortunately, a lot of people chose not to take advantage of that, and they did stay home. I think if you look back during that time period during the pandemic and think how could we improve that, there's definitely some ways that we can. And one of those ways was the use of telemedicine and telehealth. Just having conversations with health professionals and being able to do assessments, even when they're not in person, could have avoided some delay in healthcare needs. And so I think that's something that is in place, and even now today as we go forward, we're going to continue to encourage patients to use telehealth and telemedicine visits. The third area is a national one that we saw happen, not just here in Maryland, but across the country, and that was the deployment of critical items like supplies, equipment, facility readiness, and staffing. Unfortunately, what we saw across the country was when there was a critical need, whether it was a ventilator, whether it was medical supplies, whether it was how we needed to access staffing and increase staffing, there was a significant competition amongst not just healthcare systems, but airports, schools, employers, about getting access to some of these same supplies and needs that we had in the hospital field. And what I'll be working towards in working with my colleagues and making sure that we do even a better job of this going forward is educating our elected officials, people that are in the supply chain area, employers that are producing really critical meds, medications, to make sure that we have a much better organized way of deployment, so that a hospital who's trying to save lives isn't competing with the local airport for PPE, that there's a clear sense of direction on what is the most important need when it comes to PPE or access to major equipment. And that includes looking at the dependence on other countries. With over 60 to 70% of medical supplies coming from countries outside the US, our country's got to do a better job of ensuring that that critical supply chain is in place so that we can be ready for if this were to happen again. Even though this happened only once in 100 years, we must be prepared as a country to do that. And that's not a political statement, that's a preparation statement. We're fortunate in Montgomery County to have a strong emergency preparedness model. We collaborate really well together with the hospitals, and even during this pandemic, we were talking every week and sometimes daily about how we could support each other and the patients that we were serving right here in Montgomery County. So I would, those are the kind of three lessons I would say, Bridget, that I take away. There's many more, but those are top of mind for me this afternoon. I wanted to share.
Thank you, Terry. And you definitely outlined the importance of it's not only the healthcare worker going in, but they have families and lives, and it has impacted them as well, but they continue to be on the forefront. And we do need to encourage others to go into medicine or be nurses or radiology technologists, medical imaging. So thank you. I appreciate that. And it definitely has shaped the model of what we provide. So thank you. I appreciate your input on this. Question number 4. This is for TJ Senker. TJ Senker is the president and vice president of MedStar Montgomery Medical Center. And TJ, I would like to ask the question of, from a business perspective, how has COVID-19 impacted hospitals in the future of healthcare delivery? What do you see as where we are now, and where do you think we're going to be going?
Thanks, Bridget, and good afternoon to everyone. Obviously, the pandemic's been quite impactful on a variety of different levels as we've had to adapt our operations to meet the challenge at hand across all the facilities. As Dr. Coots talked about, we canceled elective surgeries, we closed outpatient offices, and we had to bring in additional crisis staff to support our teams, all of which had a hopefully short-term impact on our bottom lines. But while we're today seeing those volumes slowly come back, it may be months before we have a real sense of what our new normal will be. Unfortunately, many patients, as you've heard, are still anxious about coming to the hospital, and they're delaying care. And whether that's a surgery or a visit to the emergency department, and all of our facilities are doing our best to communicate that we're safe for patients to return. In fact, I would tell anyone who would listen during the peak of the crisis that I felt safer in the hospital than I did virtually anywhere else except for home. And that was an amazing stat for us, is that we haven't had a single ED physician or associate who has tested positive for the virus, despite the fact that 100% of our COVID patients have come through the emergency department. So that speaks to obviously the cleanliness, the safety, the PPE, and just the vigilance of everybody involved. So it may be some time before we fully understand the go-forward implications of COVID, but I think there will be some realignment of health delivery priorities based on some of the things that we've learned, including, and Terry referenced this, improving the scalability of the digital patient experience and improving access through telemedicine. Here at MedStar, prior to the crisis, we had about 150 to 250 e-visits per week. And in the first week of the crisis, we had over 500 a day. And so being able to utilize that technology, obviously during the crisis, was critical, but that's something that as we go forward to continue to improve access to various services, that will continue to be critical. Second is around finding better ways to address underlying causes of health inequities, such as differences in socioeconomic conditions, access to early screening and care, and underlying disease risk of different populations. And we saw this with different patient populations responding differently to the virus and at different points over the course of time. And then the third, and Terry mentioned this as well, but is really about addressing new and emerging behavioral health needs during a period of rising stress levels. And that was a crisis before this began that's only been exacerbated as we've gone through it. From a leadership perspective, as our team has reflected on the crisis and our crisis response over the past several months, there's 4 key elements that stick out as approaches and behaviors that we'd like to continue moving forward, including the first is the ability to focus on the essential few priorities that we were able to really hone in on COVID and be agile to respond to new challenges as they arose without being distracted by less critical issues. And so this is impacting our planning in future years as we strive to go deeper versus wider on key areas of focus. Second is around the continued cultivation of an environment where we can fail forward fast, enabling speed in our response and approach, but also innovation and different ways of thinking that aren't impeded by the fear of failure. And healthcare in particular, I think, moves slowly, typically. We did not have that luxury during this crisis. And so it really forced us to innovate and be nimble and agile and test and try new things. And I think that that's something that will continue to be important. The third is that leadership matters, and I think we all know this, but we have an incredible team of leaders here and at all the facilities across Montgomery County. We were able to deploy many leaders in new and novel ways to solve the problems at hand. And so as we go forward, I think we need to continue to provide opportunities for leaders to move beyond historic job descriptions and comfort zones and help them help us advance the organization in new and different ways. And then the final one that was mentioned earlier is no surprise, the emphasis on communication. Whatever the issue at hand, we simply can't communicate enough, and that was clear throughout this crisis as we were trying to give confidence to our associates that they had the latest and greatest guidance when it came to CDC recommendations and usage of PPE and so forth. And so while COVID has really challenged us in a variety of ways, financially, from a care delivery standpoint and from a leadership standpoint, I feel good about some of the learning that it's enabled and how that's going to impact how we provide care in the years to come. Let's turn it back to you, Bridget.
Thank you, TJ. That was very well put. And I love how the underlying theme with all of our presidents are really coming from the same focus, as well as the community needs and where we are going moving forward. It's ever evolving. It's almost a Pandora's box. And the support that we have in the leaders that are on this panel is astounding. So thank you. I appreciate it. So thank you, TJ. Okay, next I would like to introduce, and I have spoken his name, this will be the third time, Andy Catenzero. He is a physician with Adventist Healthcare. He is infectious disease and epidemiology. So thank you for joining us, Andy.
My pleasure,
I appreciate
Bridget.
you coming with us and joining. I have a few questions, and as we know, COVID is ever evolving. Every day there's something new, which is going to be my first question to you. The CDC has put out guidance over the last 48 hours and changed what we need to be doing from an asymptomatic as well as isolation. Could you please touch on the basis of what that means, CDC versus Maryland, and then the specifics around isolation and asymptomatic patients?
Sure. Thank you, Bridget, for this opportunity to tell to speak about this. So the CDC sets, if you will, the floor for the recommendations for the nation. And what they most recently said can be superseded or really have a greater authority from local authorities, such as the governor of Maryland, to set a higher standard. But you can't set a standard lower than what the CDC has recommended. So the CDC's recommendations now are a slight change, I would say, in how we address people who don't have symptoms and who come in contact with somebody who they know has an infection. And what they've said basically is that, if you're in a vulnerable population, consider testing, in a vulnerable population. And I think the broad-based message for this audience is, that if people have, on the other hand, the governor, I should say, set the floor, if you will, a little bit higher than that, to say that anybody who has a desire to get a test can get a test. All they have to do is request it. And so what I would say for the general audience, by and large, is if you have employees who would like to get a test, they can get a test by requesting one through their healthcare provider, going to an urgent care, going to a testing center when they reopen in Montgomery County. And our governor has given, basically permission for a provider to give a test independent of symptoms. And that's the bottom line. We set the floor, if you will, a little bit higher than the CDC does. And the idea behind that testing is that the more testing we do, the more we'll identify cases. The more we identify cases, the more likely we are to isolate individuals who have the disease before they spread it to others. And so I think it's good practice for business leaders to recognize if an employee wants a test, they can get it. And then, probably want to have a plan prepared with what does the employer do if that individual tests positive and they have to have ongoing work that they need to do. Can they work off site? Can they take a leave of absence if they're asymptomatic, et cetera. So those are the main, I think, the highest level, if you will, of testing. These will continue to evolve. I'm sure we'll hear more from the governor, so stay tuned on this regard. But at this point, I don't see it changing a lot of our practices at any health center because we're governed by what the healthcare orders are from the governor of our state.
Well, just to reiterate, we are still testing in the state of Maryland asymptomatic patients as well as patients who are people who feel that they may have been cross-contaminated. And can you enlighten me a little more on isolation? What is the stance from Maryland? How long after an exposure or when you are COVID positive you should isolate?
So this has been an evolving story, and the CDC still sets the standard for that. So as it changes, the CDC will change their recommendation. I think that's one of the things as leaders across our community we're going to have to get used to, is that these recommendations do change very frequently. Since January, we've drawn up plans, torn them up, rewritten them in literally a day or less. And that's a very uncomfortable situation. It's hard to plan, but the CDC is, for us, at least the healthcare systems, the true north as far as setting many of these standards. So the CDC would tell us if an individual tests positive and they have no symptoms, at a healthcare system, they would not be coming back to work for 10 days. And after 10 days, they would have no infectious virus for the average employee. If they're immune suppressed, they have chemotherapy, et cetera, advanced HIV, it may be a different scenario, a bit longer, 20 some days. If they have symptoms, then having a continual dialogue and understanding how much have they improved. We are not using testing to, I'm just going to underscore that, we are not using testing to tell somebody that they are free of disease or that they're free of infectivity. We're using time and symptoms really as our two markers of when people have resolved the infection. And the public health department in Maryland is happy to walk people through their individual scenarios. They've done that for a lot of us. We as a healthcare system have taken that on in our occupational health department, and I know some of the larger employers have done the same. But that's the bottom line. I think this will change, but the CDC still has it right as far as the time frame for excluding people who are infectious.
So what I hear you saying, this is what you do in the hospital, and I know we have a lot of people online that are business owners, or so would you recommend the same guidelines then for their companies, for their employees?
That's right. 10 days, is if they test positive, that will minimize spread in your environment. Even if an individual is wearing a mask, I don't think it's safe for them to go back to be working within 6 feet of other people or in the same office space or office room. It'll certainly create a great deal of commotion for symptomatic people to come back to work, and it just won't be a very comfortable situation or a safe situation. So I think as businesses are coming back in line and beginning to plan for the future, having some sort of redundancy, some sort of cross training, if you will, that's what we've had to do in healthcare. If I'm out, I know who my replacement is for 10 days at a minimum, if I can't do my work.
Thank you. Another question that has been posed is, tell us a little bit about plasma transfusions. I know there's a lot in the media about that.
Sure.
Can you just give us a brief overview of what that means?
Sure. So human plasma is a third part, if you will, maybe a fourth part of the armamentarium when people are hospitalized with COVID-19. Human plasma is the portion of our blood that contains antibodies that fight against viruses. We are using what's called convalescent plasma after someone has been infected. They have antibodies to the virus that may be very useful for someone who is experiencing the virus as a therapeutic. So that plasma is collected by a blood bank in our area, that's Silver Spring, or in Inova, and then it can be transfused to a patient who is sick with COVID-19. It's a very promising, it's very promising. It has a statistically significant impact on people who are infectious. I'm not going to go into how much it affects people, but it does, I think, have an impact and a role in the treatment, of what can be a deadly disease for people. There are really 4 treatments that we deploy in the hospital. One would be oxygen, which can be life-saving to make sure the individual can maintain their oxygenation for all their vital organs. The second would be a drug called remdesivir, which is provided by the federal government, which has an activity against the virus itself, and then when it is used in patients in the hospital, can alter the course. The third is a steroid called dexamethasone that decreases the inflammation to the virus, and that is used. And then the fourth, I would consider part of the four-part treatment, if you will, for hospitalized patients would be convalescent plasma. So it joins, if you will, the treatment paradigm to improve the outcomes. And I think each one has a small but statistically relevant impact. And my hope is that in the coming weeks to months, we'll understand what the combination therapy really, how that benefits people compared to how we saw the virus very early in the spring. We had a lot of people pass away, regrettably, in the early spring of this year. And my hope is that with these advancements, each one small, each one statistically significant, each one having an impact, will have a better impact on patient outcomes than we did before.
Another question I have for you. Can you talk to me about testing strategy so that everyone on this panel that is listening can understand what are the different testing strategies out there, and maybe go into a little bit of just touch on the validity and sensitivity of them so they know where they land and maybe can advise their employees and others on what they should be doing for testing.
Sure. So the testing is evolving almost as fast as the recommendations and the therapies. So they're really moving very quickly, and some of our partners in Quest and in our hospital-based labs are, really expanding the number of testing, and it's really an exciting time as a physician and epidemiologist to see how many things are coming online so quickly. In my experience, the gold standard is the nasal swab, which is kind of the go-to testing for most of the testing centers, including when the county was running them, that as well. And that's a PCR test that amplifies the genetic material of the virus to make a determination. That testing is probably right now the gold standard. Second in line, which is coming along very quickly, is an oral swab or a saliva test to measure the presence of the virus. That's been getting a lot of media attention because some of these tests are very rapid and very sensitive and very specific. We haven't deployed any of those in the healthcare system yet because they don't really meet our needs yet, but we will see, I think, that evolving. The blood tests or the serology are probably the weakest of the three. They look back 3, 6 months or longer to see what is the evidence in the blood that an individual has had COVID-19. And those are probably the least sensitive of all of them and have the highest challenge for the individual patient as to what they mean. So I think a large organization like many of the healthcare systems will collect that information for planning for the fall, but for individual patient care, for individual businesses, that's probably going to be the least useful of all the kind of testing that's going on. There are more that are going to be developed. It's almost impossible to keep track of how many tests are being developed, but those are kind of broad strokes that we can use. And what we've seen is the turnaround time, in the hospital is different than we can get that in the doctor's office, different than we get in the urgent care. So, you may see some turnaround time in the hospital as quickly as 5 hours because we have the testing machines right there. There's no transport time, and we don't have tens of thousands of specimens. On the other hand, sometimes the urgent cares or doctor's offices may be delayed in how quickly they can get the results. Sometimes that's 48 hours. Other times it's as long as 7 days. I've heard some reports as long as 8 or 9 days for some of these large testing. And it really depends on how many tests they get and how quickly they can put them on the machine and get them back out again. Those limitations are going to be very real for large systems. I was talking to the state today. They're having turnaround times as long as 7 or 8 days for nursing homes, for example, because of the volume of people who need to get tested. Those will get better over time, but right now, it's really, I think if someone's going to get a test, it's a fair question to say, well, when do I reasonably expect to get the results back? And then you can plan accordingly, make some decisions about what you need to do in your life as you're waiting for those results to come back.
Thank you, Andy. And just two more questions. I'm sorry, it's not very often we have an epidemiologist that we can ask these questions, but they are very important ones. Vaccines, can you give us an update on that? And then also, again, any other medicines that are looking promising out there that you're willing to share or can share with us?
Sure. So the vaccines, I'll separate out, non-COVID and COVID vaccines because they're really very different. So at this coming season, you'll hear from the CDC, from all the hospitals, all the doctors' offices, really at every corner, a hue and cry to update your vaccines to be sure you're vaccinated, because so many of these symptoms that we see from COVID-19 can be confused for other preventable diseases, whether it's flu, whether it's streptococcal pneumonia, whether it's pertussis, whether it's, even things that are preventable in kids, all the hepatitis, all these vaccines that are so important for us. If you can get those vaccines updated and current and get a flu shot, you take a lot of the concern out of the provider who sees you if you have a fever, and you can prevent that. And it may actually prevent the spread. If, for example, an individual got the flu, they could be less likely to have a cough and a sneeze and whatnot, and potentially minimize the spread of COVID-19 down the road. So all the vaccines that, I'm very, as an epidemiologist, a physician, infectious disease, I'm very pro-vaccine. That should come as no surprise to any of you. So updating your vaccine and getting a flu shot, talk to your provider about, are there any gaps? I just saw my healthcare provider. I got one vaccine in my right arm and I got one vaccine in my left arm, and we're good to go. So, I had to get updated. And so I think it's important that everyone, considers that in their own healthcare and say, based on my age, based on my risk factors, what do I need to do to protect myself in the fall from everything else? As far as COVID-19 is concerned for the vaccine, those vaccine trials are going on right now in our community. And so I was talking to a colleague of mine who's volunteering as part of the Moderna vaccine. There are 150 vaccines that are being evaluated currently for COVID-19. Some of them are in what I would say advanced clinical trials, phase 3. Others are moving along quickly. We don't know what benefit they will come to bring. The projections are sometime between, November and the first quarter of 2021 that will have information about their efficacy. But if people are interested, going online, finding out where a vaccine trial is being done is a very valuable service to the community. And you may not know this about my past, but I ran vaccine clinical trials at the NIH for 3 years, and it's very rewarding for the participant as well as the researchers to see community support coming. When people come to say to you, and they say, I trust the scientific community and want to volunteer, it's really a big deal for vaccine design. So I think we'll know more about the timeline in the coming weeks to months, but I would project we'll know, conservatively, we'll probably know by the first quarter of 2021, which, if any of these vaccines show efficacy and how strong it is. And then as far as new medications, I can say it's a very exciting time for infectious disease physicians, including myself. All across our region in Montgomery County, we have very strong research institutions that are doing clinical trials. None of them are quite, quote unquote, ready for prime time. In the case that I want to talk about them as really being, available for new medications and have gone to the FDA. But I know that, Holy Cross, Johns Hopkins, Adventist Healthcare, MedStar are all running clinical trials for inpatients testing new approaches for this deadly disease. And so, I think all of the hospitals in this region recognize that research, science, clinical trials are the only way out of this terrible, terrible problem. And that by working together, recruiting patients when they come to us, offering them a clinical trial, I think will be part of our way of operating business in the future as we start to look for how we can treat this virus most optimally. The only way we have all the medicines we use is through a clinical trial. And so those things are happening at a very rapid volume now. And there's a lot of promise, but I'm not quite ready to say any one product is better than the other that's coming. I don't see anything on the immediate horizon, but you know, if I look at tomorrow morning's Washington Post, I may see something completely different.
Understood. And thank you for that. That's very important. And what I hear from you is the common denominator of get your flu shot. It's going to help armor you against COVID and other diseases. And it's more important this year than any year. So
I put all vaccines in that category. So, you know, every year we move ahead one more year, and all of us, our kids and our grandkids, think it's worth having these conversations for all of us is, you know, are you updated with all your vaccines? There will be a lot of emphasis on the flu, but I also saw a lot of people coming into the hospital with vaccine preventable pneumonias. And so it's a good time and for us all to be updating ourselves, asking our employees, check with your doctor, are there any vaccines that you're missing? Give them a little time to go to their doctor and make sure that they get it. Those can be done by telemedicine too, by and large, you know, so there are telemedicine visits and they can be called to the pharmacy and the pharmacy can administer them. So they're not an undue burden to get updated. A lot of this can happen very quickly. So I want to really kind of broaden that conversation to make sure that we think about all of our vaccines so we can maintain our health. It's just so important this time of year.
Very well put. Thank you. Okay, so moving into the next phase of the panel discussion, we had asked if anyone had questions to please write it in our meeting chat. And I see that Jody Staub has asked a question. How will this pandemic impact the future of healthcare design and building so that any future crisis is easier in years to come? So on our panel, who would like to answer that question for us?
I can take an initial stab at that if you want, Bridget, because I think there's some things that we've already modified our hospitals. So a lot of our hospitals, we immediately started to move air out of the building. So to minimize as much as we could, recirculating air, unfortunately less energy efficient, but safer for healthcare inside the hospital, is to move air out of the hospital as much as possible. So some of those redesigns, as we're looking at it, you know, really are ways to mitigate, you know, keeping viral particles in the hospital. So I think that's where we feel the most safe, is that our ICU at one point, 100% of the air was going right out the hospital without being recirculated at all. The same with some of our OR airs. And I think all the hospitals are going through with a fine-tooth comb to look and see how much of the air can they move to the outside. The other is, how does traffic move through the hospital so that people who come into the healthcare system are assessed. We have automatic temperature checks at our front doors now, so that you can just step up to a station, it says green light, go, and takes your temperature and gives you a number. So those kind of designs really, I think, you'll see more in businesses, that you can take your own temperature when you walk in the door and kind of step up. It does infrared temperature on your forehead, and you just stand in front of it. Pretty high-tech stuff. And then the other is to control access points. So we've done a lot of work to control how visitors can enter the system, so we know who's on our facility. And I think all businesses, you know, will begin to think about that, so that we have as much control for people coming in, and we ask them the screening questions. So those are some kind of high-level redesigns I think that hospitals are doing immediately to accommodate business.
Would any of our presidents like to offer what they feel would be the answer to this from your standpoint? Dr. Coots, I see you smiling.
Yeah, so I think one of the things too, one of the lessons that we learned from this was the fragility of the national supply chain, with so much of our supply chain being offshore. I think that everyone recognizes that, and the absolute lack of redundancy that we had here in the continental United States really cost us significantly. So I know that most of the health systems are starting to stockpile supplies to be prepared for, whatever gaps come next. But the biggest thing is that ultimately we do need to move production back to the United States, at least at a redundant level of production to be able to have it. The other thing too is, we're a special pathogen assessment hospital, so because of Ebola, so we had access to the national stockpiles. And when we opened those, we found that while the masks were good, the material of the mask, the rubber bands that held the mask to your face were all brittle and everything. And so, the lesson learned there is in the future, in building these national stockpiles, is ensuring that there's a system of rotation of stocks. And that's just good supply maintenance procedures to be able to do that. And then I think moving ahead, all of us expanded our ICU capability. Many of us converted previously decommissioned space into new space to treat these patients. And we're working with the authorities to ensure that future decommissioning after this pandemic is over simply means leaving those in a turnkey status, so that the next time something like this hits us, we don't have to start from scratch to recreate the space that we spent money and time and effort creating for this, that all we'll have to do is turn the key and open those up again. And so full of equipment and everything that is monitored and is checked routinely to ensure that it's ready for the next time. And then fundamentally, I think this is the age of telehealth and telemedicine now. There's no going back. Now that horse is out of the barn, we cannot go backwards on that, because the access that it has given our patients to healthcare from their home, from their work, from their car, wherever it is that they accessed us on whatever type of device they had, there's been a high level of satisfaction, and it's been actually very, very good to be able to keep in contact with our patients and even continue to monitor our chronic patients that are out there as well. So future development, the second and third order effects of this, how do we snap all of this together and really put healthcare where it really needs to be, which is as close to the home as possible, if not in the home, will continue to change the way we practice medicine, and actually will make it safer. I mean, if you need to come to the hospital, feel safe and confident to come. But if you don't need to come, you can access that same high quality level of healthcare from where you want it or need to access it. And I think that's the future. We were waiting for CVS, Aetna, whoever it was, to be the disruptor, but the pandemic turned out to be the disruptor. And I think will fundamentally change the way we practice medicine and provide healthcare moving forward.
I agree. Very well put, Dr. Coots. TJ, would you like to speak a little bit about your facility and your system?
I would just echo really all of those comments. I mean, I think in particular, the telemedicine discussion, and that is the future. The access that provides, and the ability for patients not to have to come, to our facilities to receive care. So I think that requires a lot more thought in terms of how we continue to develop that capability. There's some regulatory issues that still have to be worked out as well on a permanent basis, but assuming those all can be resolved, I think that's a large part of the future.
And Terry, would you like to add for your healthcare system any input on this to echo what they're saying, or any additional information?
I'd say just on the design of new healthcare spaces, infectious disease has been around the last 10 years. We certainly haven't seen it to this degree, but in the past cases that we saw with other SARS cases, it has already made that impact to how hospital design is being done. So any new construction projects within the last, I'd say 5 to 8 years have started to really take account for how to do an excellent job with infectious disease. But I think this has taken it to another level, and we'll continue to see the influence on architectural design and the way privacy and patient rooms are designed in the future for patients that do need hospitalized care.
Thank you. Very good. So I'm going to ask do people that are in attendance, do you have any more questions, please type it into our meeting chat so that we can give you an opportunity to go right to our leaders at the helm so that they can answer your questions. I think that was the only question that I saw posed within our chat.
Actually, I'd like to jump in and ask a question. I really am happy about the construction question because many people have talked about that, about what the facility, the impact of the facility, and that of course led us to telehealth, which has been, really standing in the wings for a while. It's not that it didn't exist, but this really was the disruptor. I think that was a great expression. And I'm wondering, so this will certainly impact how you work with construction companies and as you redesign spaces. But how are you working with health IT companies to help with information, the kind of information you're gathering? Is there an opportunity? How are you partnering with or contracting with our companies that are on that end of the information to help you better respond to this? And that's a question for all of our leaders on the panel.
So I think, if it's okay, I'll jump in first on that one. And I'll say really one of the things is that's really coming to the forefront is artificial intelligence. Artificial intelligence is now being applied across the broad spectrum of healthcare, from surveillance to diagnosis to treatment. And I think we'll see significantly more of that interface with our existing systems. Early warning systems, there's a program that's out now that's designed for skilled nursing facilities that basically extracts all of their electronic data and analyzes very subtle changes that have been annotated in the data as an early warning that, hey, this patient might actually be coming down with COVID or might be coming down with something else, or just might be at risk of needing to be admitted to the hospital. So the more things like that come out, the better we'll be able to serve the community and really be prepared, very, very proactive as opposed to reactive, because a lot of healthcare is still very reactive. And so this is sort of changing that paradigm. The other thing I think that is going to impact us on the way we move forward, design patient rooms and things like that, with the absence of visitors, with the absence of family members, there was an awful lot of how's the best way to put it? Patients were isolated. I mean, and you could see it in the way they reacted. I mean, patients were alone. Usually they would have somebody sitting with them. There was an increased risk of patient falls because nobody was in the room with them. There were articles that got lost, that got thrown out with the trash because there was no family member in the room with them to take positive control over those things, and the lack of direct communication with family members. So we started implementing iPads and things so that patients could talk. But there's technology now so that on those information boards that are in each of the patient rooms, there's actually a camera and a video screen so that if the doctor, the nurse want to talk to the family member while the patient is in the room, they can turn that on. And that type of communication, having it in already built into the room, would relieve you from having to walk in with an iPad or a laptop or, hey, Mrs. Jones, is your cell phone charged? Your daughter wants you to call her, type of thing. So I think that's the future too, integrating all of that IT into the patient's rooms to make the communication with family members and loved ones that much easier.
Thank you, Dr. Coots. Any Terry, TJ, would you like to add anything into this?
I think Dr. Coots described it pretty well. I don't know that I have a lot to add to that point. We're going to definitely see a lot more available information to patients, not only just hospital information, but information from the pharmacy, their physician base. I mean, healthcare can't operate in silos to be effective. We need to have the information readily available at the time we need it. And I do think that's an area that will keep getting better quickly.
there is a strong movement too of sharing data, which is now going to, I think, benefit a lot of patients. So I can now go online and see anywhere in the state if someone's had a COVID test already done, sharing that information with other providers so they can get the highest level information that they can get from the medical records. So from a patient in Holy Cross, a lot of their information is going to be uploaded into a database. So as the public is aware, we'll see the benefits coming down. We're starting to see some interoperability so that our EMRs can talk to each other and get some of the information shared that's inpatient to outpatient, which will also be a huge boon. The second call after where do we want to build something is how do we get the IT in there, because it's so vital. We're blessed that we have a new healthcare system where a lot of computers are in the room. So I think, you know, those sort of things we'll see being built out as we're adding patient towers. I know some of you all are adding patient towers, and you're adding patients. You know, we're going to have a lot of IT in the room for the providers and for the nurses to do their work. I think we'll also see a lot of the IT shared, as we've started to see, with the patients. So we now have, you know, keyboards for patients to interact with a large screen TV. How is that going to play out for a 75, 85, 95-year-old individual with, as Dr. Kuhn said, without a family member there? I think we're going to have to figure out a way to bridge that and probably bring in more family members who can use that technology, because there's going to be a gap between the people who can use the technology and the technology. It's going to be growing as the technology gets more complex. So, you know, in my family, we call it the face to ceiling ratio. A lot of times I'm calling up my father-in-law. I see a lot of the ceiling. I don't see much face. You know, we've all had that experience, but it's so important with telemedicine to have a loved one in the room to kind of bridge that gap for people who, you know, I'm seeing more of the ceiling. I can't get a lot of meaningful communication with the ceiling, so having somebody else in the room to bring that human connection to the IT, and how do we figure that out? How do we zero in on the people so that it's the lowest bar possible? I think that's where we need a lot of work in the community to say, well, how do we make it, you know, just really, really user friendly? If it's as friendly to operate as a TV, we'll get there. But if it's as friendly to operate as a cell phone, it's going to be a barrier for a lot of people.
Thank you, Dr. Catenzero. And being in respect of time, we have 6 minutes. Let's answer one quick question from Richie. Can you share with us, how are you supporting the local suppliers in Montgomery County? Anyone on the panel would like to take a stab at that one?
I can jump in on that, and feel free to add to it. I'd say there's one example that comes to mind really quick here off the top of my mind is a couple of years ago, we realized that access to actually the fresh vegetables and healthy foods to some of our team members were not readily available, or could they always afford it? And so we partnered with the local produce organization that grows vegetables locally here in Montgomery County. And then we provided actually our own farmers market for our employer, or for our employees, and discounted it based on how much they actually took home in their paycheck. And that was such a big hit the first year. We increased it this year again. And in fact, during the COVID-19 crisis, just even finding time to get to the grocery store was tough for some of our healthcare workers. So we ended up just offering it for free to them throughout the year through a farmer's market. And that's been a great partnership. A lot of the supplies we buy are national, that's for sure. Making medicines and healthcare products often is done even outside the U.S. And I'll tell you, that's a big passion I've got, is how do we change that over time and make sure healthcare products are made not only locally here, but let's get it back to the U.S.
Agreed. Thank you.
I'm hoping that before we run out of time, that we have an opportunity to receive sort of a parting shot. You know, what do each of our presidents want to make sure that all of our businesses here before they leave? Because one of our goals here is to bring everybody up to speed so that they feel confident about using hospitals to get their regular health care back in place. You know, and it's been said, so that's been helpful. But Parting shots. We've got you here. It's a rare opportunity, and we'd like to hear, something you'd like us to remember.
Well, and prior to that, Gigi, we do have one question that snuck in. Ben Wu from MCCC. His question centers around collaboration and how it's been incredible about how county hospitals have been collaborating together. So maybe if you could tie in kind of potential future collaborations that you'll be making, especially with our thriving life science industry. So tie that into a positive kind of last shot.
Perfect.
So I can start on this, and we're fortunate to have a formal partnership between the county hospitals in the form of something we call Nexus Montgomery. And that started with funding from the state initially, and we've collaborated over the years on a number of different issues really related to population health and issues around behavioral health and senior services and different things that it makes sense for us to partner together. And obviously the pandemic gives us a whole new range of issues that we've been discussing and we'll continue to collaborate on as we go forward. It's definitely strength across all of the county hospitals working together.
So one of the ways I can talk about that question is we are partnering at the hospital I work at with Oncommune, which is a local producer of therapeutics. And I'm not sure if we're supposed to say a brand name, but I'll basically say that, we have life sciences producing organization that produces therapeutics, novel therapeutics. And they reached out to us because of our previous connections, and they're collaborating with us for producing a medication that may work against COVID-19. Those collaborations came out from previous connections with cardiovascular research, with oncology research, and now those companies are coming to us and saying, what can Montgomery County residents get in the form of a research project? And having a really good partner locally means there's a lot less supply chain issues. There's a lot more flexibility in how we can work together and recruit patients and have an ongoing dialogue to get things done as quickly as possible. So we do have a very vibrant biotech and nascent biotech technology group and biotherapeutics. And I'm sure, seeing those, fostering those business connections, fostering those private hospital communications can just build this area, to be much like, I would say some of the biotech values of Southern California, Northern California, and other areas. So we see a lot of promise in this area. There's a high collection of people who are vulnerable to these. And, I think the more we can talk about this through research or through, and these are not just government research, this is private research to private hospitals, private research to community hospitals to benefit the community writ large and the nation. So I think as we look at those and maybe having another communication about what sort of activities our businesses, cooperating and working and collaborating with healthcare, it's a good way to talk about some of our successes, and then other people may have other ideas to move their products. The same is true with some of the advances in healthcare protection to protect the environment. Some of our collaborators now are looking at ultraviolet light, robots. These are all being made in our area. And so I think the more connections we can have and more thought behind that and brain power behind, how do we rethink how we do medicine in our area, the better off we'll all be.
Bridget, I'll put a quick, a huge thank you to local county government, council members, state, and national. I'd say, there's lots of things we can improve, but we should also take time and really make sure we give a lot of credit to all of our leaders, Democratic, Republican, Independent. Everybody got behind about how can we address this together. And I think the way forward from an economic response is going to require that same kind of commitment. When we went through a national healthcare crisis, it took everybody pulling in the same way. And we saw that with our county executive, council members, our governor, and even our national support. So I'm very grateful for that.
Thank you. Thank you. Gigi, since it is now 6:01, would you like to do a wrap up?
I was just going to say, Dr. Coots, did you want to throw anything else in there? For the good of the order, come on.
Yeah, I would just say, you know, we are your county hospitals and health systems. Just as your workforces are important to you, your workforces and you are important to us.
Very well put.
Well put, and I think that's a great note for us to wrap up on. So please, everyone who's that joined us today, we want to thank you for being with us today and participating. And please join me in a huge thank you to our panelists, Jackie Schultz, Dr. Norvell Van Coots, of course, Terry Forde, TJ Senker, and Andy Catenzero. And thank you also, Bridget, for building this and working with us to make this happen today. Thank you all for being with us, and until next time. Thank you.
Thank you, everyone. Have a good evening.